one of our third-year residents. She's going to talk to us about how to talk to our adolescent patients that we know are so difficult sometimes. Dr. Rhodes has a reputation of being able to connect with adolescents, and we think she's very good at getting to the heart of their issues, and so we're excited to hear what she's going to teach us today.
Thank you. Good morning, everybody. Thank you, Dr. Mike, for that introduction. As many of you know, I really am passionate about teens, so teens is definitely a topic that was nothing to think about to do for this grand round. So I hope that you all like it and that you take something from it, because we all know we're in clinic and you pick up that teenage chart and I see a lot of people go, oh, it's a teenager, like I don't want to have to go in there. So I felt like this was kind of important, because even though we don't really like to deal with them, well, I like to deal with them, we have to see them in the pediatric population. So hopefully this will be helpful. So the title of this Peds Grand Rounds is Don't Get It Twisted, How to Achieve Straight Communication with Adolescents. I have no relationship with any industry to disclose relevant to any of the content of this CME activity. And my objectives. So one, I want to outline strategies and techniques to approach the adolescent visit. Two, demonstrate psychosocial screening tools for the adolescent visit. And three, illustrate the use of motivational interviewing to achieve a better visit outcome. So just a few teen health facts. Approximately 20% of adolescents have chronic health problems, and most morbidity and mortality are due to intentional and unintentional injuries, often rooted in their behaviors. And some of the things that can cause them to have these unintentional or intentional injuries are use of alcohol, tobacco, other drugs, depression, unplanned pregnancy, and STDs. Many U.S. adolescents underuse the healthcare system, males greater than females, and most tend to use emergency departments, free clinics, and family planning clinics for primary care. So some teen visit facts. Physician visits with teens are typically short. The mean duration is anywhere from 15 to 16 minutes, and counseling or education is given in about 50% of those visits. And what is it that these teens want to see from their healthcare professional? They want to see that their healthcare professional is honest, knowledgeable, and experienced. They're going to treat them equally, emphasize confidentiality, which is very important to teens, and relates with the teens. And a good thing about being able to keep these things in mind is that this helps promote teen health through open communication between the physician and the adolescent. So how should clinic be set up for teens? So if there's a clinic setting that has a wide variety of age groups, it'll be important to schedule times that would allow there to be for just teenagers to be there, because it makes them feel more comfortable while they're in the waiting room, as opposed to they're already at this awkward stage and feeling like they're almost grown and they're not grown, and then you're in here with a baby and 2- and 3-year-olds running around. It just kind of makes it a little awkward for them. Also, it allows you to be able to provide materials that are not appropriate for younger age patients in the waiting areas and in the examination room. So because of that, you can place a video that is, about STDs, or a video that's about something more pertinent to the adolescent population that you couldn't do for the younger population. Brochures, pamphlets, any kind of devices for display. We have quite a few devices for different types of like contraception use and things of that nature that you couldn't really have up if there was a younger population there. So that's definitely something to think about. And then for material that's a little bit more sensitive, you would want to put those in the individual exam rooms, just because it'll be awkward to go over if you want to see what chlamydia is and other people are looking, and you just want to be unobserved during that time. So put more sensitive information in the individual exam rooms. So how to approach the adolescent visit? Just like the guy in this picture, most of you guys want to run. But hopefully the strategies outlined here will kind of put you a little bit more at ease and give you some techniques and strategies to help make this adolescent visit go a little bit better. So we're all medical doctors, so even though my presentation is more on the psychosocial screenings and how to better communicate with our patients, we still have to keep in mind that we have to treat them health-wise. So I went to the Bright Futures, which thanks to Dr. C-Card is a very helpful tool, and it shows different things that we should be screening for. And screening should be done once in early adolescence, which is considered ages 11 to 14 years old. Again, at mid-adolescence, which is 15 to 17 years old, and late adolescence, which most of us probably won't see, which is 18 to 21 years old. And some of the things that you would screen for, of course, is vision, which would be once in each of those 3 time periods, which you would use the Snellen chart. And then based on the history provided during the exam, be it on their medical history or their psychosocial history, you would want to screen for the other things listed, as well as their vision, their hearing, if there's any concerns for anemia, tuberculosis, dyslipidemia, STIs, pregnancy, cervical dysplasia, or any alcohol or drug use. And based on the risk assessment, then you would take into action, like I mentioned on the further column of things to do in order to screen those patients. So what are the priorities of this visit? I also took this from Bright Futures as well, and what it states is that you want to focus on the physical growth and development of the patient. So in this time, you want to ask them about their physical and oral health, their views of body image, healthy eating and physical activity. You also want to focus on their social and academic competence. And with this, you want to find out their connectedness with their family, with their peers, with their community, their interpersonal relationships, their school performance. You also want to take a look at their emotional well-being, how they cope with things, how they regulate their moods, their mental health, and their sexuality. You also want to evaluate their risk reduction, and with this, you want to find out if there's any tobacco or alcohol use or any kind of other drug use or any sexually transmitted diseases. You also have to talk about violence and injury prevention, so you always want to kind of highlight safety belts to be used in the cars as well as helmet use. And a lot of times these teenagers are going to start driving, so you want to start talking about things to do when you're driving. And then other things to talk about would be specifically on substance abuse, guns, and interpersonal violence. Dating violence and bullying is real, and depending on some of the patient populations, they might experience more violence. And so there are some tools and questions to ask that I didn't highlight in here, but it's something called FIST, and it's an acronym which can kind of show you what questions to ask in order to examine more of a violent area. So during the initial encounter, you want to let them know that this begins the transition from the parent to the patient being seen as the medical historian. And so you want to establish the patient's concerns, because we all know we have those parents that come in the room and you are looking at the teenager or you're looking at the child and they answer everything for them and you're like, okay, I'm talking to Bob, but they still answer everything for them. So you want to make them feel like their concerns are valid, because because they're their parents, but we still have to remember that the teenager is our patient. You also want to obtain any family history during this time, inquire about any previous medical problems, and then you're going to want to ask the parents next to wait in the waiting room so that you can speak to the adolescent privately. And I know that we get some parents are resistant to doing this. For the most part, there are a lot that be like, oh yeah, they need to start answering on their own. I'll be glad to leave out. But for those resistant parents, which we do get on occasion, you want to express to those parents that it's important for the adolescent to have a relationship with their physician so that they can have someone that they can confide in to discuss difficult issues that may arise in the future. And then you want to reassure them that they'll come back in at the end of the encounter and they'll be invited back to the room to discuss any remaining issues that they have, so that they don't feel as if you're trying to completely leave them out. So when you're interviewing the adolescent alone, you definitely want to establish a rapport with the patient. And this is important because you want the patient to know that they have a separate relationship with you as the physician. And so this allows you to gain the adolescent's trust and to be seen as an advocate for them. One thing you definitely want to avoid when you are establishing a rapport, though, is using a lot of slang, because it's not your usual dialogue, and they can kind of tell. So you don't want to be like, yo, homie, how you doing today? You know what I mean? It just sounds ridiculous, so don't even try it. But you also want to address issues of consent, confidentiality, and limits early on in the visit, because for the adolescent, this is the part that's really, really, really important, is knowing that if I tell you this, are you going to truly keep this a secret, or are you going to, as soon as my mom walks back in here, just, throw me under the bus? So you really want to establish this rapport with them, okay? You want to start the interview in a non-threatening conversation. So start it off with asking them about their hobbies or any current events that are going on. And this will ease your anxiety, and it'll foster a rapport and trust with the patient, and encourage more disclosure. So consent for medical treatment for minors is something I think we should kind of be a little bit more aware of. We've all had separate little instances where things have happened and you didn't know what you could say, when to say it, how to say it. But this kind of outlines just generically, and then you also want to know for your state, because every state has some more specific guidelines and laws based on their consent for minors. So of course I'm going to focus on Louisiana because we are in Louisiana, but when you go out, we all go out and practice, because all of us won't be practicing here. Just make sure you know what it is for your state. I know some of us will be in Alabama and Texas and different places, so you just kind of want to know. But in general, consent by nature of the condition. So if it's emergency, definitely you are able to treat. If it's sexually transmitted disease prevention, then you are able to do that. But you also want to make sure that if there are any reportable diseases, that you report those. AIDS treatment and HIV testing, pregnancy prevention, abortion, any rape, incest, or sexual abuse, any alcohol or drug abuse, and any mental health. And you also want to know consent by virtue of the minor status, being whether they're an emancipated minor, whether it's by age or by judicial decree, or they live away from home and they manage their own finances, if they're married or if they ever have been married, if they are a member of the armed forces, if they have a child, and if they are a high school graduate or considered a mature minor in your respect. But the law requires, regardless, that if we discover that the adolescent is in danger of hurting himself or herself or others, then we need to report that to the appropriate authorities. So in Louisiana, it was a huge, longer section. So I tried to just summarize it because I didn't know what some of it, like how to word some of the legal jargon, but this is pretty much, it tells you that minors can give consent for medical treatment, surgical care, or any services by a licensed physician in the state who believes they are afflicted with any illness, disease, if they have drug abuse, if they're in labor or for childbirth or for venereal disease, and they can be treated. But the part that I wanted to have exactly how it was outlined was for our state. Specifically, it says, upon the advice and direction of a treating physician, or in the case of medical staff, any one of them, a physician or a member of a medical staff, may, but shall not be obligated to inform the spouse, parent, or guardian of any such minor as to the treatment given or needed, and such information may be given to or withheld from the spouse, parent, or guardian without the consent and over the express objection of the minor. So I know a lot of times in clinic we get results back and we're like, do we call and do we tell the parent, or do we tell the patient? And that's where you have to use the judgment as the clinician decide what you want to do. But you know now that you have the opportunity to tell versus keeping it a secret. But in some states you're not allowed to tell at all. So we're one of the states where you may tell.
Even if the minor objects.
Mm-hmm.
Right. So that's an important thing.
So consent requirements for Louisiana be it at school or what's considered a facility would be a hospital or any place that provides any kind of medical services, health unit, then you may provide preventative counseling or treatment to a child without parental consent if all the following conditions are met. The child requests such preventative counseling or treatment, the child withholds permission to contact a parent or parents to seek consent, a qualified professional reasonably determines in good faith and based on dependent evidence that seeking parental consent would not be helpful and would actually be harmful to the child. So, continuing on with our adolescent interview when it's alone, you want to know that the goal is to assist the adolescent in identifying potentially risky behaviors that may endanger their health and assessing their motivation to change those behaviors. And this is where psychosocial screening and motivational interviewing are useful. And motivational interviewing is something that we'll talk about a little further because it was something that I found along researching topics on how to deal with adolescents that I think would definitely be helpful and allow us to better communicate with our patients. So some of the psychosocial screenings that are used, we've all heard of HEADS, but do a lot of us really use it a lot? Maybe, maybe not. It just kind of depends, but I just kind of wanted to highlight it here. I won't focus a lot on it, but it's a psychosocial screening tool that focuses on the home environment, education and employment, eating, peer-related activities, drugs, sexuality, suicide, depression, and safety from injury and violence. And so as you can see here, this chart shows you that potential first-line questions. So this will be the columns that the questions that you want to definitely try to ask if you ask those in the visit. And then the column over on to the, I guess this is your left, would be the questions that if time permits that you would try to get to. And all of these questions are open-ended questions, as you can see. And just for example, in the home section here, a question that you would ask would be, who lives home with you? As opposed to you saying, does mom live at home? Does dad live at home? I mean, because it kind of sets the patient up to be a little embarrassed if they don't have either one of those at home. So you don't want to make any assumptions about what's going on in any of these areas. So it's better to have open-ended questions so that it prompts them to elaborate. And so that is kind of like what the HEADS promotes and what it's useful in getting a lot of more information for the patient. And then PGYIII, and this is something that I found in looking up information on. It's so many different screening tools that I did not know, but a lot of these were the ones that were most popularly seen and that I thought were very helpful. And PSC stands for Pediatric Symptom Checklist for Youth. And what it is a 35-item self-completion screening questionnaire that is designed to detect a broad range of behavioral and psychosocial problems in the youth population. And it can be given to the patient to complete while they're in the waiting room, so that's done while they're in the waiting room, and then by the time they come back to you, you're able to see it and look at it and kind of address things based on what they wrote on the screening tool. But it's a scoring system that is based on a 0 if they've never done it, a 1 for if they've done it sometimes, or 2 if it's done often, and the maximum score that they can get is 70. And then there's 2 additional questions that specifically focus on suicide ideation and suicidal attempt. And so those additional questions are 36 and 37. And if those are positive, then it's automatically a positive screening for this patient. But a positive score is any score that is equal to or greater than 30. And as you can see here on this questionnaire, they have different symbols, circles, they have triangles, they have squares, and they have some diamonds, okay? And so these squares and shapes kind of let you know the area that the problem may be in. And so if it's a triangle that they seem to have more of the problems that show up, then they have more of internalizing problems, which can be related to like depression and anxiety. If they have more circles, then it highlights that it's more attention problems, so it could be underlying ADHD. If they have more squares, then it's more externalizing problems such as conduct disorder or ODD. And if it's the diamonds, then it's the suicidality. And so that's kind of how that kind of breaks it down. And this also asks just simple questions that can be completed and checked off based on what the question asks of the patient. And then the next screening tool that could be used is the PGYIII, which stands for Patient Health Questionnaire Modified for Teens. And it's a 13-item questionnaire that's also another self-completion tool that helps detect depression and suicide. And this can also be given in the waiting room for the patient to check out as well. And for this, if they have a score greater than 11 or equal to 11, then it's, or if they answer positively for a suicide ideation or a suicide attempt, then it automatically is a positive screening test. And so with all three of these, the HEADS, the PSY, the PHQ, if you find any concerning results from these, then as the primary care physician, you should evaluate further and decide whether you need to do further screenings or refer them to a mental health specialist. So this is where it becomes important for you to be the advocate for the teen, because it may have been in this setting that was the first time that they actually, provided some information. So the CRAFT questionnaire, quite a few of us have either heard about and some of us may have even used, but it's a questionnaire that is a brief questionnaire for substance and alcohol use screening. And with these, it's just that they answer yes or no, and if you answer yes, then it's considered 1 point, and if it's a score greater than 2, then it's considered positive, and the adolescent is at more risk for having an alcohol or drug-related disorder and requires further assessment. So, yes, sir?
So one nice thing about those pre-visit screening tests that the adolescent can fill out in the waiting room is that gives you a natural place to dismiss the parents to say, I'm going to review with little Johnny his screening questionnaire, go out, Mom. And so that it gives you a natural way to do that.
That's so true. That's a good point, Dr. Mancheri. That's so true. So how does motivational interviewing fit into all this? So you've gathered all of this information and through the screening tools and through open-ended questions. So a motivational interview can come into play to help facilitate change in their behavior. And I thought this was pretty cool because I really hadn't heard of this before. Had a lot of people heard of motivational interviewing? Okay, good, maybe it was just me. But kind of like what this cartoon depicts here. A lot of teens think that they know everything. So it's like, when is the world going to realize that we know everything? And so using motivational interviewing kind of can help boost that kind of thought, because that's kind of how they feel at this point. But what motivational interview offers is an efficient means for targeting behavioral, developmental, and social problems. And it also enhances the patient's intrinsic motivation to change by exploring their own perspective and ambivalence. So it's using the patient to motivate them to change. This has been successfully applied to many types of behavioral goals, be it for diet and exercise change, to be compliant with contraceptive management, quitting smoking, and quitting using any illicit drugs. So what are the essential elements of motivational interviewing? So collaboration, it's a partnership between the pediatrician and the adolescent, and it positions the adolescent as the expert about his or her own beliefs, experiences, and values and their goals. And it is the adolescent's role to articulate and resolve their ambivalence about change, and it's the pediatrician's role to help guide the adolescent to examine his or her internal conflicts about their goals, values, beliefs, and their behaviors. So evocation is the use of open-ended questions and reflections to help the patient identify his or her intrinsic motivation for change. And autonomy is, clearly what it is. It's the adolescent's responsibility to change his or her behavior and decide if, how, and when that change will occur. And so, and the good thing about autonomy as a supportive or essential element here is that it proposes that direct persuasion, or that traditional lecturing and telling the patient, oh, you should be doing this, why are you doing this, why are you doing this, wagging your finger at them, is just not beneficial to the patient, and it causes them to be more resistant. So the goal of motivational interviewing is to kind of sway us away from doing that. And these elements underscore the patient's respect for the patient's perspective and their behavioral changes. So what are the principles of motivational interviewing? You want to express empathy, accepting the patient's beliefs and behaviors regardless of whether you agree with it or not. You want to accept what they're telling you. And this is more effective than applying pressure through persuasion, as mentioned previously, because of it elicits resistance. So if a patient describes a behavior to you that has a negative health impact, then you want to temporarily compartmentalize your thoughts until the patient voices everything that they have concerns about. And then you want to encourage an alliance by resisting the urge to give advice until it's requested, or at least until you ask permission for the patient before giving them the alternative point of view. So you want to let them finish first and then use these tools to better give them a different perspective. You want to develop another principle is developing discrepancy. And this is seen between the patient's current behavior and his or her goal. And so with this, you want the adolescents who are aware of their inconsistencies, they usually attempt to make a change when they become aware of the consequences of their behavior. And you want to ask the patient's permission to offer objective information about these discrepancies. You also have to know that another principle is rolling with the resistance, because you will get that as well. And recognize that it is normal to feel ambivalent about changing a behavior. And resistance usually occurs when the patient feels pushed to do something, or he or she isn't ready to make that change. And so signs of resistance would be if the patient is arguing, denying what they're doing, they're interrupting, they're missing appointments, or they're intentionally coming late to appointments, or they're just plain ignoring you as a provider. And then another one that is a lot of times people don't think about is when the patient is just overtly compliant, but they have covert defiance. And so that's another form of resistance that is signaled by if the visit is just going way too smoothly and they're agreeing just way too easily. So you also want to be able to look out for that. And then you want to support their self-efficacy, and this is done by expressing optimism towards the things and the goals that they want to achieve. So how MI works. It involves using reflective listening, which can be done in a variety of ways, which is simple reflection, which is just pretty much the patient tells you something about how they feel, and you just kind of repeat back to them. So you're telling me blah, 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 blah. And that is just like simple reflection, or reflective meaning, where you kind of infer the meaning of what they say, or reflective feeling. So there's different ways to do reflective listening. You want to use open-ended questions. You want to provide affirmations and summaries. And so a lot of patients, when they're being encouraged to talk about their thoughts and feelings, this prompts them to provide you with more information and to elaborate more. So there are some supportive techniques for using motivational interviewing. These aren't things that you have to do, but they can help you gain more information from the patient. You want to ask permission before offering information or advice. Elicit, provide, elicit, which before just launching into a lecture, you first elicit the adolescent what the adolescent already knows about a topic, and are there options for behavior change. And then there's decisional balance, and this is where you ask the patient to talk about the advantages and the disadvantages of the change that he or she is considering. And then you also can use what's called importance and confidence rulers, and this allows the patient it's a helpful tool to help them assess early on whether they're focused on reasons to change or confidence in their ability to change. So knowing all of the principles, the essential elements, and all of that is great, and that all of that is good, but all of it's going to depend on if the patient is ready to make that change. And so there are different stages of change, and these are all based on a trans-theoretical model of behavior change. And so as you can see here, it's this, kind of loop effect here, where you have pre-contemplation, where they may have increased awareness of the need to change, but just may not be ready. Then there's contemplation, where they may be motivated and have more confidence to change, and so they're kind of contemplating do it. And then the preparation stage is where they're ready to negotiate a plan to change. And then action is where they put these things into an actual commitment, and you have to follow up with them on this. And then maintenance is just them maintaining this behavior change and encouraging active problem solving in order to maintain that. And then the relapse phase, which can happen, you just want to assist in coping with this relapse and then just kind of start the cycle all over again. And there are patients where once they get to this maintenance phase, then the behavior is terminated and they've made that change. So regardless of the stage that your patient is at, you want to accept it and allow them to be at the stages wherever he or she is at, and just encourage proactive movement toward healthier behaviors. And it's important for the pediatrician to understand where the patient is at so they can know how to target their intervention effectively. So how to establish behavior change plans. This is only going to really be appropriate when the patient is in that preparation stage, as we just kind of mentioned before. Some patients want to formulate their own plan, but then there are some who will need some guidance. But regardless, a typical plan change involves the change that the patient wants to make, the most important reasons for making the change, the specific steps that they need to plan to make the change, and then finding those that can support them along the change and how they can get help by those as well, and then also qualifying how the plan is working, and then being able to identify any barriers and any solutions to those barriers. So let's put this all into practical use. I have a little case study here. Janie is a 16-year-old junior in high school who comes in for a follow-up of a new prescription for contraception. She is sexually active with one male partner and has started on oral contraceptive 4 months ago. Janie states that she stopped taking the pill a month ago. So what do you do next? Wait, is my patient Janie here?
Dr. Rhodes, I'm right here.
Oh, can you come on? I'm so happy to see you too. Let's see here. What did I do with my little sheet? Sorry guys, I'm missing something. Huh? No, it's not this. What happened? So I'll have to improvise. Sorry, a little technical difficulty.
That's okay. I'm so glad you made my mom step out. I didn't want to talk about this in front of her.
Hi, Janie.
Hi, Dr. Rhodes.
So what brings you in today?
Well, I wanted to talk about the pill with you. So, unfortunately, I stopped taking it about a month ago because I was just having a lot of spotting, like even when it wasn't my cycle. So, I just stopped.
Okay. How did taking the pill at the same time every day work for you?
Oh, Dr. Rhodes. I mean, I tried everything, but I just could, no matter what I tried, I just could not take it every day. I mean, I'm busy. I just couldn't do it.
Okay. Well, thank you for being honest, Janie. I mean, it's difficult. Thanks for being honest about your difficulty to take the pill every day.
Yeah, no, but I mean, Dr. Rhodes, I'm really concerned because I'm really hoping to be a dancer for Beyonce one day. So pregnancy is just not in the realm of possibilities right now. So I mean, I need to do something. I don't know. Maybe I'll just stick with condoms for right now, or I don't know. Maybe when I go back to school in the fall, it'll be easier. I don't know.
Okay. Well, what do you think will work to help make you take the pills consistently?
Well, I mean, I always have my phone with me in case my boyfriend calls. So, I don't know, maybe I could set an alarm.
Okay, well, it sounds like you've thought about the issue, and set an alarm on your phone is a good start. What do you know about other contraceptive methods?
Well, I know that shot thing makes you fat, so I'm not interested in that. I don't know.
Okay. Well, would you like me to tell you about other options?
Absolutely. I mean, I got to do something.
Okay. So we're acting like we're talking about the different other options. Okay. Are any of these of interest to you?
That Nexplanon thing sounds interesting.
Okay. Well, it's totally your decision. Would you like for me to set up something today, or would you like to have more time to read more on it?
Well, let's go ahead and set up something today, and then I'll read whatever you give me when I get home, and then we can kind of go from there. But I guess until then, we'll do the alarm thing so I don't forget to take my pill.
Okay. Well, we can definitely set that up. And while you're here today, let's go ahead and set your alarm and see what time you want to take it. And that way we can kind of see that you're putting that plan in motion.
Okay.
I'm so proud of you for taking responsibility for your health.
Thanks, Dr. Rhodes.
Wasn't Janie great? But only reason why I kind of wanted to do an actual demonstration is just because I can sit here and tell you what all of these things mean, but until you kind of see how to use it, it kind of really doesn't mean much. And so, but you have to find what works for you and how to use these different things. And so that's why these tools are out there to kind of help us be able to put them into practical use. So the effectiveness of motivational interviewing. So I looked into it to kind of see if there had been any research done to show how much it has been effective. Did I look up a whole bunch? No, but it definitely were some that I found. And so there was a motivational interviewing, a systemic review and meta-analysis that was done in 2005. And it pretty much took 16 different databases, and from that database, they were able to find 72 randomized control studies that allowed them to analyze the effectiveness of this particular motivational interviewing. And so some of the facts that were found were that the encounters that were 60 minutes showed that there was 81% effectiveness in 26 out of 32 of the trials. And then for encounters that were less than 20 minutes, 64% showed an effect, and that was seen in 7 out of 11 of the trials. And then the likelihood of the effect rose with the number of encounters that there were, and an effect was demonstrated in 40% of the studies with one counseling session, and 87% of the studies with more than 5 encounters. And medical doctors obtained an effect of motivational interviewing in 83% of the studies. And there were different, in this particular study, a meta-analysis, there were psychologists and psychiatrists that were also counselors, but because we're medical doctors, I just focused on the results for the medical doctors. And then there's evidence that has been to look at just in the pediatric population, and there's several studies that have been done, but definitely there's a need for more studies. And pretty much what they have done is it's been for specific things. So there was a study done in 2004 by McCambridge and Strang, and with this one, it was about for substance use. And they had a control group and they had a randomized motor innovational group, and it showed a reduce in use of cigarettes, alcohol, marijuana, and mainly through the moderation of ongoing use rather than complete cessation. And this one focused on the results more so in the effect size, and it used to show that there was a reduction in the use of those things, which showed a significant difference in those groups. And then the AAP has done an assessment of brief MI counseling on the family diet, activity, and media use for children at risk for obesity. And this was done in 2012, and it showed positive changes for behavior towards diet, reducing their screen time, and increasing their physical activity. So there definitely have been some studies that have been done. There also have been ones showing the effect in alcohol use as well as diabetes. So who's teen ready? This picture I thought was funny because there are going to be a few hands are up, and then everybody else who's pointing to like somebody else is ready, or you're still kind of like, okay, maybe, but hopefully something here was helpful. So how do you wrap up the visit? So before calling the patient's parents back into the room, you want to consult with them about what will be discussed and what will remain confidential. And then you want to invite the parents back to the room and then conclude the actual visit. And you want to discuss the findings and address any concerns. And both the adolescent and the parents should be offered a chance to ask questions. And the parents may ask to see the physician alone. And this can be accomplished during the time where the patient is changing for the physical exam or at the beginning before you start the initial discussion with the adolescent. But you always want to keep in mind and remember that the teen, not the parent, is your patient. So in summary, it's important to establish open communication with your adolescent in order to improve the visit outcomes. Using psychosocial screening and motivational interviewing are useful tools to help improve the adolescent visit. And the emergence of more research on the role of MI on the behavior change would be beneficial to increase support and usage to effectively improve adolescent health. And one thing I wanted to mention is that they do training for motivational interviewing. What I did here was just kind of a brief demonstration of the principles and the essentials, but it's a lot more comprehensive than what I showed you all. But they have a website for anyone who's interested in looking up more about it at www.motivationalinterviewing.org, and they outline different places where they go in different states and cities to do training and have seminars and things of that nature. So any questions?
So what do you do when the teen discloses something to you and says, don't tell my mama, I don't need her to know, and then mom comes in and insists that she needs to know?
I mean, that's a case where you have to kind of be able to tell the parent, you know, I'm here for the patient, and I have to, you know, keep the confidence of what the patient confided to me. But if it's something that is a danger to their health, then know that I will, you know, let you know that. But I'm here to allow the patient to confide in me so that I can, you know, help better their health.
I know one of the things I used to do is if the teen would tell me something that was either risky behavior or they did have something that was a health issue that needed to be treated, I'd tell them, you know, your parents need to know. You can tell them, I can tell them, or we can tell them together.
Mm-hmm.
So not telling them was never really an option.
Mm-hmm.
And so usually they wanted mom in the room, and then either they would tell or I would tell, but we were all in the room together.
Mm-hmm.
But when I had them alone, I'd tell, you know, mom really needs to know about this because you're going to have to come back, you're going to have people come, mom's going to get a bill in the mail, you know,
Mm-hmm.
those kind of things. And that usually went over okay.
Yeah, and we use that in clinic a lot when we have the patients that have some stuff that they really need to tell the parents, and they really are receptive to that, or more receptive to having you in the room to tell their parents. But then there's those cases too where you have to also think about if telling the parent would be more harmful to the patient than helpful. And so, but I definitely think that is definitely a useful tool.
You know, the practical problem that always seems to be, we're always talking about counseling. And when you're in practice, as you say, you're seeing people for probably 5-10 minutes on most interviews. How can you really do a motivational interview? You may be able to do it once or twice on a patient, or you know, while you're seeing them over a period of years, but there's no way you're going to be able to do this on every patient all the time. You're going to be driving a bicycle.
Right, and that was the whole point of why you can't do all of this in one visit. It has to be done over several visits, 3, 4, maybe 5 or 6 visits, depending on the patient. But you want to try to do some every time to where you get some benefit of it, but you won't be able to tackle all of it in one visit. That's so true, Dr. Herb.
I think another critical time that you can use this technique is in the preteens, because you've got sort of middle school kids who are just, you know, boys and girls stuff is kind of coming up, and body image is really an important thing. And so you can begin to use this type of technique with preteens and really get some wins and connection with them that sets the stage for a really good adolescence and relationship when they're adolescents. Because even a preteen is, they may be, looking and thinking, well, I'm fat compared to the other kids in my class, and they may be highly motivated by you as a pediatrician, talking with them about that and helping them develop their own plan for, not eating ice cream every night after dinner, something simple that a preteen can do. And then you've helped give them positive reinforcement that builds your relationship for the adolescents. And so that continuity over time is worth an awful lot.
Exactly. Well, thank you guys.